Our topic for this lecture is gastrointestinal system disorders. Specifically, we'll focus on issues of motility, ulceration, inflammatory bowel disorders, and pancreatitis. The specific objectives, as you can see, is to be able to discuss common upper as well as lower GI pathologies as they relate to motility and ulceration. And it's important you be able to differentiate among inflammatory bowel disease pathologies. Finally, we'll be able to compare the pathology and the pathophysiologic effects of both acute and chronic pancreatitis. Please be sure that you take a look and understand that you are responsible for describing risk factors and basic pathologies of some of the specific GI cancers. And the specific cancers that you're responsible for are esophageal, gastric, colon, and pancreatic cancers. So please be sure that you take a look at that. Let's start off talking about motility disorders. And when we think about motility, we frequently either talk about motility that's too fast or too slow. But the first thing we're going to talk about is diarrhea. Not a terribly pleasant topic, I suppose, but one that you will encounter regardless of what age group you work with and that you'll see a lot in your practice. Diarrhea specifically, chronic diarrhea specifically defined, is greater or equal to 3 loose stools or greater or equal to 3 liquid stools per day. In order for it to be chronic, it has to be these frequent liquid stools have to have been present for at least 2 weeks. So there are diagnostic criteria that would differentiate between an acute diarrhea and a chronic diarrhea. In general, we look at 3 categories of diarrhea: osmotic, secretory, and motility. So let's take a look at each one of these and think about some of the pathologies that are the things that might lead to this pathology. So when we think about an osmotic diarrhea, what we're specifically looking at are things that would cause water to be drawn into the intestinal lumen. So there are some things that may actually lead to that. Some of the most common things include tube feedings. Generally, when you're giving a tube feeding, if you give a hyperosmolar tube feeding, and many of our tube feedings are hyperosmolar, that can cause water to be drawn into the intestines. And you've probably experienced that in your patients who have been tube fed. This may be due to medicines. One of the most common medicines is sorbitol. Now, we use sorbitol. Remember, this is a sugar that is not absorbable, and we use that specifically to actually draw water into the intestinal lumen. We use sorbitol, and medicines that have sorbitol in them can actually cause an osmotic diarrhea. The third thing that can cause this type of pathology is gastric resection. And what happens with a gastric resection, when you remove part of that stomach, you actually, it results in a dumping syndrome. So instead of the foods leaving the stomach in a more, a bit more digested or less bulky state, it's very bulky, it dumps into the intestine, and once again, pulls water into the intestine, causing those loose or liquid stools. Secretory diarrheas are very common. In secretory diarrheas, what we're looking at is the end result would be either an increased chloride or bicarbonate secretion by the mucus, or there is less sodium absorption that happens with the intestinal lumen. In general, secretory diarrheas tend to be very large volume diarrheas because of all of the gastric secretions that are being pushed through. Common pathologies related to secretory diarrhea include infection, endo or exotoxins, and inflammatory bowel disease. So with infection, that makes sense. If you get a salmonella or if you get a giardia, you can see how the intestinal environment would change and there would be more secretion there. One of the most common things we run into in the hospital is toxin produced by C. difficile or Clostridium difficile. Recall that C. difficile is a spore, and this is very commonly a healthcare acquired or antibiotic associated diarrhea, and again it is secretory. The highest risk from antibiotic therapy include the cephalosporins, the quinolones, clindamycin. And again, it's not so important that you at this point in your career have the specific antibiotics memorized, but understanding that pretty much potentially any antibiotic may lead to a secretory diarrhea. Now with C. difficile, because we see so much of it as a healthcare acquired secretory diarrhea, is that we know that we can test for the toxin because the C. difficile, that spore, actually makes a toxin that we can test for. The difficulty with C. difficile is that the individual may actually develop a C. difficile colitis as well as recurrent C. difficile infection. So it can become chronic, or you can tamp it down for a little bit, and it recurs fairly frequently. So what we have to do, the biggest thing we have to do then is if you think about this spore, what's the best thing we can do in order to overcome that? Well, we either have to tamp down the spore, which we do through our medication therapy, but the other thing is allow the intestine to repopulate its normal flora. So that becomes critical in a secretory diarrhea from a toxin. The third type, or the third pathology that can lead to a secretory diarrhea is inflammatory bowel disease. We're going to talk about inflammatory bowel disease specifically, but what is different in an inflammatory bowel disease from the other two that we talked about in this category is this tends to have a smaller volume of diarrhea stools. If it's an infectious process or a toxic process, tends to be a large volume diarrhea as opposed to a much smaller volume diarrhea in inflammatory bowel disease. The third type of diarrhea is usually motility related. So when we look at pathologies that are related to motility, one of the things we have to remember is that the GI tract moves, and especially the intestines, move by peristalsis. And that peristaltic action is partially controlled by pacemaker cells that initiate the peristalsis and are influenced by some of our hormones from the upper stomach all the way through the pylorus and into the intestine. So when we think about the hormones then that affect motility, we think about gastrin and motilin. These are small intestine hormones that actually facilitate motility. Secretin is another hormone present in the secreted by the small intestine, but secretin actually inhibits motility. So gastrin and motilin facilitate motility. Secretin inhibits motility, and all three of these hormones are secreted in the small intestine. And it's important then that those hormones be in balance. So if gastric and motilin are increased, like typical hormones, the feedback loop should then decrease them and stop their secretion. If we need to speed up the GI tract, feedback would say, hey, I need more gastrin, I need more motilin, so you would have more of those hormones coming out. They would be secreted in larger amounts. Some of the other things some of the pathologies that can lead to motility defects, especially increased motility, include a short intestine. Could be neuropathy, for example, a diabetic-related neuropathy, both in type 1 and type 2, as well as hyperthyroidism. So all of these things can cause alterations in motility, and in this context, we're talking about increased motility. Like inflammatory bowel disease, motility-based diarrheas tend to be smaller volume than what you'll see in a secretory diarrhea from an infection or a toxic effect. Now, clearly, some of our concerns with diarrhea would be the negative effects on fluid, electrolyte, and acid-base balance. So the fluid part makes a lot of sense, especially in those large volume secretory as well as osmotic diarrheas. Electrolyte balance we would be concerned with include chloride, sodium, potassium, bicarbonate. And as we think about acid-base balance, what kind of acid-base imbalance would these patients most likely develop? This is once again, shout at the screen. Those of you that said a non-anion gap or normal gap acidosis were absolutely correct. So this would cause a normal anion gap metabolic acidosis. And remember, especially we're thinking about something that would be happening chronically. Let's turn our attention to the lower GI tract and think about lower GI dysmotility. And let's think about things that slow us down. So the first thing we often think about is paralytic ileus. And it's important that we know the difference between paralytic ileus and decreased motility from a paralytic ileus versus adhesions versus a mass that may be impinging in the lower GI tract, especially lower GI tract. So when we think about a paralytic ileus, this is usually a functional obstruction, and there are numerous causes of this functional obstruction. And this could be anything from medicines to a postoperative phase. And in the postoperative phase, there is also the suggestion that there are inflammatory mediators that become involved in decreasing the motility. Adhesions are probably the most common cause of decreased GI motility, most likely to be acute as opposed to chronic. And an adhesion means that there has been fibrous tissue that has developed and has either obstructed the lumen or has narrowed the lumen. And then last but not least, is there a mass there? We especially are concerned about this with colon masses, or it could be from a stricture of a diverticulum that has become very narrowed. With dysmotility, decreased motility, we know that there is a risk of ischemia, and that ischemia can then lead to infarct. Because as you slow things down and you put an obstruction in that system, it is more likely to become ischemic and therefore infarct. So let's differentiate a bit then between small bowel obstruction and large bowel obstruction. When we think about a small bowel obstruction, we are especially concerned with fluid, electrolytes, and gases that are collecting proximal to the obstruction. As a result then, with that distension from the gas especially, that then will lead to a decreased ability to absorb both water and electrolytes. Therefore, there's going to be a net increase of secretion into the lumen. That then continues to increase that distension. There's also a risk with small bowel obstruction of a metabolic acidosis. Now, with a metabolic acidosis, this is more likely if this is lower in the small bowel as opposed to higher in the small bowel. So actually in a small bowel obstruction, you may have an alkalotic or an acidotic state depending on where the obstruction is. So let's walk through that a little bit. So if you have someone who has a small bowel obstruction very high in the small intestine, they are more likely to be alkalotic due to emesis and dehydration. Now with that emesis, remember you're going to have the loss of hydrogen, potassium, and chloride. With that loss of hydrogen, potassium, and chloride, the kidneys will reabsorb bicarbonate, and they will actually then decrease more of the chloride, worsening the alkalosis. So that's why we think about alkalosis early as well as in a higher small intestine obstruction. As we move lower in the small bowel, however, if the individual has an obstruction lower in the small bowel, they are more likely to develop a metabolic acidosis. And this is due to the ischemia that will develop because of this this large amount of distension that is occurring, and with that ischemic process will be the collection of lactate, and we know that lactate is an acid, and they would develop an acidosis. With a large bowel obstruction, generally the most common area is dilation of the cecum, and with that dilation of the cecum, there is an increase in the intraluminal pressure, and as that intraluminal pressure goes higher than the capillary pressure, that would then lead to an ischemic process. So once again, if you think about both small bowel obstructions as well as large bowel obstruction, the commonality there is the distension from either gases or secretions that is causing more intraluminal pressure. But it's important to be able to differentiate between the two. So the consequences of a intestinal obstruction relate to the onset as well as the location, because we want to remember that the important area is the tract that is proximal to the obstruction. When that tract proximal to the obstruction becomes ischemic because of that increased intraluminal pressure, you have an increased risk for perforation. With that perforation then comes a risk of peritonitis, because it's going to perforate into the peritoneum. That intraluminal pressure can also, because of the decreased venous return, cause edema of the intestinal wall, which then increases capillary permeability and increases the probability of translocation of bacteria and bacterial toxins that normally live in our bowel into the circulation itself. So lots of things then to think about when we think about bowel obstruction, not only the obstruction itself, but the effect of those obstructions and the distension of those obstructions on our acid-base balance, as well as leading to ischemia, and how that ischemia then can not only lead to peritonitis, but can also increase capillary permeability and facilitate translocation of bacteria. Let's turn our attention now to also gastrointestinal bleeding. When we think about GI bleeding, the effect on homeostasis is going to be extremely variable. And the effect on homeostasis depends primarily on where the bleed is, the location, how fast the bleed is, and the amount of bleeding. In general, though, when you think about GI bleeding, think about it as a symptom of underlying pathology. Because what you really have to do in someone who is GI bleeding is find out why they're bleeding and where the bleed is. Now, GI bleeds can be either in the upper or in the lower GI tract. So when we think about upper versus lower, some things to consider include hematemesis, whether or not there is coffee ground stool, hematoschezia, and melena. So let's talk about each one of those. With hematemesis, we are talking about generally is going to be higher in the GI tract, and especially be thinking about whether or not this could be in the esophagus. When someone has a large volume of bright red bleeding in their emesis, take a look at the esophagus, because it's coming out very, very rapidly, and we know that esophageal varices, especially in liver disease, tend to bleed pretty excessively. When someone presents with coffee ground stool, we know that the blood has been in the GI tract for a while, and as a result, there has been, for lack of a better phrase, some digestion of that blood, and it has been changed by the colon. That's why it looks like coffee grounds. It's darker. With hematoschezia, this is bright red stool, and this is blood itself, and it's bright red stool, so it's coming from the rectum. Now, this could be either lower GI, or it is possible that this could be an upper GI bleed that has been transited very, very rapidly through the GI tract. With melena, these are dark red, sticky stools. Frequently, this represents a GI bleed that is higher in the GI tract, perhaps an upper GI bleed, or high in the jejunum, which is part of your small intestine. So having a sense of what the blood or the bleeding looks like and how it presents can help us begin to narrow down where the pathology actually is, and may even help us identify some of the pathology. The other piece that we should always be concerned with in GI bleeding is whether or not this is occult bleeding. So with occult bleeding, this is someone who has something that has a very slow bleed, so they're kind of bleeding all the time. It's not transiting through the GI tract very rapidly, but there's always just something occurring there. This is one of our concerns with colon cancer, which is why we do occult bleeding tests as one of our screens for colon cancer. Now, another thing to think about when you think about GI bleeding is anemia, isn't it? So let's think about anemia a little bit. Let's think about a slow versus an acute bleed. So with a slow GI bleed, which is what you would see with an occult bleeding, or maybe someone who presents with frequent coffee ground stools or even melena, eventually someone with a slow GI bleed would develop what kind of anemia? Correct. Microcytic, hypochromic, primarily iron deficiency. And this would present this way because with this slow GI bleed, they continue to make red cells, but they will eventually deplete their iron stores. So eventually, many of these patients with a slow GI bleed or an occult bleed will present with an iron deficiency anemia, microcytic hypochromic. Now, if someone has an acute GI bleed and they have either hematemesis or they have hematoschisia, what kind of anemia would they develop? Correct. It would be normocytic, normochromic. Because they aren't iron deficient, they haven't had time to deplete their iron stores, and so this would be like an acute blood loss anemia, which would be normo and normo. So let's take a closer look at some ulcerations. We'll talk about peptic. Peptic is a very broad category, very descriptive, so we'll kind of use that as an overview. But then we're going to talk about stress-related mucosal disease, gastric ulceration, and duodenal ulceration. Those are the three most common that we frequently will confront. So peptic ulcer is actually a very, very broad descriptive category of ulceration. And when we think about peptic ulcers, we want to think about H. pylori infection. Remember, H. pylori is the Helicobacter pylori, which is a gram-negative family bacteria. The H. pylori actually, that bacteria adheres to the stomach and the duodenal walls. Now, what's interesting about this bacteria, this H. pylori, is that it suppresses acid secretion. And as it suppresses acid secretion, that's how the bacteria changes its environment so that it continues to grow. So the way this bacteria is able to continue growing within the stomach and the duodenum is because it changes its environment by suppressing acid secretion, therefore grows. The other fairly common cause of a peptic ulcer or peptic ulceration is non-steroidal anti-inflammatory meds. And we know that these are over-the-counter as well as by prescription, and pretty much everybody's got ibuprofen or aspirin in their medicine cabinet. And that's why you have to remember how these medicines work. Non-steroidal anti-inflammatory medicines work primarily by decreasing the synthesis of prostaglandins. With the decrease of the prostaglandins, what happens in the GI tract is that you have that results in a decrease in the secretion of bicarbonate and an increase in the secretion of hydrochloric acid. So once again, you've changed that environment and now you have caused an ulceration. In general, regardless of the cause of an ulceration, in all cases, the key to ulceration is breakdown of the mucosal barrier. Remember that that mucosal barrier in the GI tract, throughout our GI tract is an incredibly protective barrier. So if that barrier is broken, either by more hydrochloric acid being secreted, not enough bicarb being secreted, by bacteria changing the environment, that mucosal barrier breaks down and then makes ulceration more likely. Let's look then at some specific pathologies. The first is stress-related mucosal disease. This is something that we not only see in individuals who are ill, but also we try to protect our patients from this. And you'll see this especially in the intensive care units, both in children as well as in adults. Another broad term that some folks will call this is a Curling's ulcer, but I think we're getting away from that, and we're really labeling this more commonly as stress-related mucosal disease, because that's really what it is. A stress-related mucosal ulceration disease usually develops within 24 hours of an acute or a critical illness, or may develop within that. It can occur later, but that's when we really have to be very alert for within that first 24-hour period. What happens here is you have both a histamine as well as a blood flow etiology. So remember that histamine is released with the stress response, and we're especially concerned about H2, the histamine 2 receptors. So with that stress response, that acute stress response, histamine will be released. At the same time, we know that with our stress response, blood will be, our circulatory system, our hemostasis, blood shunts away from the GI tract. And because it's not the highest priority, lungs, brain, heart gets a higher priority. So as that blood shunts away from the GI tract, this then stimulates both an ischemic as well as an inflammatory response. Because of the ischemia and the inflammation, that then breaks down that mucosal barrier, and with the breakdown of the mucosal barrier, bacteria translocates from the intestinal lumen into the circulation. If that happens, then what can the patient then potentially develop? Sepsis. Good. So what about gastric ulcers? It took us a long time to figure this out, and the individual who figured it out talked about the H. pylori being the major player in a gastric ulcer for many, many years before anyone actually believed him. Remember that H. pylori is something that we all have. It's part of our normal flora. So we know then, in order for this H. pylori to become pathogenic, and remember it's a gram-negative bacteria, in order for it to become pathogenic, something in our environment has to change. And once again, this can either be a change in the environment, or a change in our own ability to suppress and keep the H. pylori under control. Another cause of GI ulceration is actually Zollinger-Ellison syndrome. And I mention this because this is something that is present and maybe is a different reason for a gastric ulcer. What happens in ZE syndrome or Zollinger-Ellison syndrome is there is an increase in gastrin. Because of the increase in gastrin, there is more gastric acid, and that then leads to a gastrinoma, which is an abnormal area within the gastric mucosa. The last type of ulceration we'll talk about briefly is a duodenal ulceration. Duodenal ulcerations are generally due to increased hydrochloric acid as well as the activity of pepsin. One of the differences in the manifestation between a duodenal and a gastric ulcer is this, in a duodenal ulcer you have a pain, food, relief syndrome. And what that means is an individual with a duodenal ulcer will have discomfort. Then when they eat something, they get relief. This is not true of a gastric ulcer. Now, interestingly though, and it's important to remember, is duodenal ulcers are much more common than gastric ulcers, except in some specific populations. Now, you know what my interest is, so you only get one guess of of a population in which gastric ulcer is more common than a duodenal. Correct. End-stage kidney disease. Individuals with end-stage kidney disease have a higher incidence of gastric ulcer than the general population, and so we are fairly alert to that as well. So with a couple of these areas already addressed, now let's talk about inflammatory bowel disease. We're going to talk specifically about three inflammation-based bowel diseases, and then we're also going to talk about a fourth, which is irritable bowel disease. That's not an inflammatory bowel disease, but I've included it in our discussion here because there are some things that help us differentiate all four pathologies. So let's start off with inflammatory bowel disease. And frequently when we talk about inflammatory or bowel disease, we think about ulcerative colitis and Crohn's disease. And I do expect that you'll be able to differentiate between these two and also differentiate these two with diverticulitis. There is a great table in your text, and it's table 41-5, and I encourage you to take a look at that because it's a real good table. Let's start by talking about ulcerative colitis. Ulcerative colitis, as well as Crohn's disease, but ulcerative colitis has a relapsing remitting characteristic. And we know that the severity of ulcerative colitis is based on the number of stools that the individual has each day. And remember, ulcerative colitis is a small volume secretory diarrhea characteristic. Now, we aren't completely certain exactly what causes ulcerative colitis, but we do know that it affects the colon and especially the rectum. So that's important. Some of the etiologies that we continue to investigate include an immune system link, and probably this is most likely where the basic pathology is. So if you look at someone if you did some lab work on someone with an ulcerative colitis, you would see some of your inflammatory markers would certainly be elevated. So the sedimentation rate would be elevated, but we know that's very, very broad. Some of the theories related to the immune system include the influence of IgG, the increase in plasma cells, as well as inflammatory cytokines. We know that one of the things that we've identified in ulcerative colitis is that T cells, which are these cytotoxic T cells that are present, are very damaging to the epithelium. When we look at the cytokines specifically, and again, plasma cells, not as sure about that one, but with the cytokines, when we look at the inflammatory cytokines, we're talking about a lot of the interleukins, 1, 2, 6, 8, 10, wow, lots of them, right? As well as tumor necrosis factor. Some of the key characteristics of ulcerative colitis include, when you look at that colon, especially in that rectum, what you'll see are continuous lesions within the lumen. And these lesions are limited to the mucosa within that area. Important characteristic. Patients frequently present with a bloody mucousy diarrhea, again, smaller volume, and they have an urge to defecate as well as an urgency to defecate. So as a result, they will tell you that they have stool frequency, small volumes of diarrhea, and they have a cramping, defecation, and relief pattern. And when they need to go, they need to go. And you've probably seen some of the ads on television about not wanting to get too far from the bathroom sometimes, because when they have to go, they need to know where the bathroom is because there is that urgency there. With ulcerative colitis, there is an increased risk of of GI obstruction, as well as an increased risk of colon cancer. So we increase our surveillance in individuals with this disorder. Now let's take a look at a second very commonly known inflammatory bowel disease, which is Crohn's disease. Crohn's disease is also characterized by a relapsing, remitting pattern. However, as you can see, it affects a different part of the colon. It specifically affects the ileocecal region, the small intestine, and some parts of the colon. So different parts of this. The other piece of Crohn's disease that is a little different from ulcerative colitis is that there seems to be more evidence supporting a genetic component with Crohn's disease. And the genetic link seems to relate to innate immunity, and it's at the NOD2 gene. The NOD2 gene helps us with the ability to locate as well as destroy invading bacteria, especially including both gram-positive as well as gram-negative. Now, we've also, with Crohn's disease, though, identified some other genes that are responsible for that inflammatory pathway and cell autophagy. In individuals with Crohn's disease, they've actually found high levels of E. coli in these patients. And what they've identified with these high levels of E. coli is that this E. coli survives and is able to multiply within the macrophages as well as the epithelial cells. As a result, then, this E. coli remains active, and the macrophages then secrete tumor necrosis factor, therefore promoting a chronic antigenic stimulation. So we've got a little bit different understanding then about both the genetics and how this genetics plays out in Crohn's disease. And that aggressive response to normal bacterial flora is what I was talking about with that E. coli infection, or the E. coli, high levels of E. coli. Key characteristics of Crohn's disease, as you can see, differ from those of ulcerative colitis. With Crohn's disease, this is characterized by skip lesions as opposed to continuous lesions with ulcerative colitis. And the lesions in Crohn's disease tend to be transmural as opposed to limited to the mucosal layer in ulcerative colitis. However, Crohn's disease also presents as bloody, mucousy, small volume diarrhea, but is less frequent than ulcerative colitis, so less stool frequency than you'll see in ulcerative colitis. Now, again, remember where this pathology is. Pathology is primarily in the small intestine or in that ileocecal region. As a result, then, you will see more nutritional deficits and more vitamin deficits in someone with Crohn's disease than you do in ulcerative colitis because of where this pathology occurs. In Crohn's disease, because this is a transmural pathology, there's an increased risk of abscess, perforation of the colon, but also has an increased risk of colon cancer. The other thing with both ulcerative colitis and Crohn's disease is that they are, I won't say frequently, but they are associated with disorders outside the GI tract. Ulcerative colitis perhaps a bit more than Crohn's, but two things that we look for are arthritis and uveitis and iritis in these individuals as well. So these are disorders outside the GI tract that have been associated with UC and Crohn's disease. The third inflammation-based bowel disease that we'll talk about is diverticulosis, and specifically diverticulitis. With diverticulosis and diverticulitis, osis means abnormal outpouching, itis means inflammation of the abnormal herniation or outpouching. The left colon is the most common site for diverticulosis and diverticulitis. So once again, you've got a difference in where this pathology is occurring. You can localize it a bit, and this is much more common as we get older. What happens in diverticulosis is the mucosa actually herniates through the smooth muscle layer of the colon wall. So these are sac-like herniations. And some of these herniations are thought to be due to a decrease in the amount of fiber in the diet. And as a result of these herniations, these sac-like herniations, there is an increase in the intraluminal pressure actually within the left colon in that area, which then you've got more and more pressure facilitating the herniation. Now, when these herniations become inflamed or infected, now you have diverticulitis. Because of this, some of our concerns that we would have, remember these are sac-like herniations, and we know that herniated areas have more friable and more permeable walls. We would be concerned with abscess formation, frank herniation, obstruction, and these can also rupture. So you can actually have a ruptured diverticulum that can become a medical emergency. And you can imagine what's going to happen systemically with a ruptured diverticulum, with all of that being dumped into the peritoneal cavity and potentially then migrating to the vascular system and causing sepsis. The last disease is irritable bowel disease. Now, again, this is not an inflammatory bowel disease, but I include it here because, again, this is something that we are seeing in women a little bit more than men. Tends to be in young adulthood, but we are seeing it in some late teens. This is a functional disorder, and it's called a functional disorder because there are no specific altered structures or biochemical processes to date that have been identified. Now, there are several hypotheses, including hypersensitivity of the viscerum, abnormal GI motility or secretion, food allergy and intolerance is one of the major components or hypotheses that we've looked at, as well as potentially psychosocial. In many individuals, there may be food triggers. Menses in a woman can actually trigger their irritable bowel disease, and emotional upset can trigger irritable bowel disease. In many cases, irritable bowel disease is arrived at as a pathology because we've ruled out everything else that we can. We've ruled out celiac disease. We've ruled out gluten sensitivity. So there are many things that we've been able to rule out. Irritable bowel disease is generally characterized by diarrhea, constipation, or both. And so that's why careful history and exam will be very, very important. Now, what is different with irritable bowel disease that is very different from both ulcerative colitis and Crohn's disease is that there is no increased risk of colon cancer in these individuals. The last thing we'll talk about in this part of our lecture is pancreatitis. Pancreatitis may be either acute or chronic and occurs on a continuum of mild to severe. When we think about pancreatitis, especially acute pancreatitis, we think about pathologies that are related to either alcohol or an obstructive process. Adverse drug reactions can also cause a pancreatitis but are less common. When we look at, and pancreatitis occurs across the age ranges. So for example, in an adult, the most common disorders or the most common etiologies of the pathology are alcohol or gallbladder disease, which would be an obstructive process of the bile ducts. In children, the most common pathologies relate to biliary system abnormalities. Now, this could be gallbladder disease, but could be an inborn biliary system stricture. Medications are a bit more likely to cause pancreatitis in a child than in an adult. Trauma is a very big player in children, or it could also be systemic disease, cystic fibrosis. So what we see in pancreatitis is an elevation of the pancreatic enzymes. Specifically, the two enzymes that we look at are amylase and lipase. Now, we know that lipase is a better indicator of pathology in the pancreas, and we use it as both a marker as well as a trend as someone is recovering from their pancreatitis. What happens with this elevation of pancreatic enzymes is that proteolytic enzymes actually cause autodigestion of the pancreatic tissue. When you start breaking down that pancreatic tissue with those proteolytic enzymes, that then stimulates the inflammatory process. With that inflammatory process, that you would see the pro-inflammatory cytokines as well as the vasoactive peptides that we usually see with that inflammatory process. So most of this on the acute side is going to be fairly well, that acute inflammatory process continues to inflame more and more of the pancreatic tissue. Now, we know, however, that pancreatitis can have systemic effects that lead to additional pathologies. About 75% of individuals with an acute pancreatitis will have pulmonary complications. The most common pulmonary complication is a pleural effusion. Now, once again, shout at the screen. What type of pleural effusion would this be? Would this be transudative or would it be exudative? Exudative, yes. So when we look, if you would tap this pleural effusion, then you would find that it would be bloody. It would have lactic dehydrogenase. It would have amylase in it. The second pulmonary complication that can occur is an acute lung injury. Again, think about this inflammatory process. Additional complications can include a pancreas abscess formation. Individuals may develop sepsis, or they may develop a systemic inflammatory response syndrome. So pancreatitis, especially an acute pancreatitis, is not without risk and pathology. In chronic pancreatitis may either be due to repeated or relapsing and frequent acute pancreatitis that becomes chronic and it kind of smolders a little bit. But with a chronic pancreatitis, that tissue gradually is replaced by fibrotic or calcified tissue. And we know that as that tissue becomes fibrotic or calcified, it is more likely to develop cysts, develop strictures within the pancreas itself, which then would lead to altered glucose metabolism, steatorrhea, protein deficiencies, or can actually cause obstruction within the pancreas itself. There continues to be a risk of pseudocyst development as well as abscess development with a chronic pancreatitis. But the big key there is that differentiates chronic with acute is the development and the replacement of normal tissue with that fibrotic or calcified tissue. The other place that you may see either acute or a chronic pancreatitis is in cystic fibrosis. You see a higher prevalence of pancreatitis in children or anyone with cystic fibrosis because of an obstructive pathology. Remember, those bile ducts pancreatic ducts are going to be obstructed by this very, very thick mucus. So in this part, we've looked at several pathologies, many of which have an inflammatory or an inflammation-based component. It's important that you be able to differentiate among the types of diarrhea as well as look at GI motility and look at small versus large bowel obstruction. Can you compare and contrast ulcerative colitis with Crohn's disease with diverticulitis? And then taking one more look at how pancreatitis can be a significant as well as serious pathology, both on the acute side as well as chronic pancreatitis. I appreciate your attention. Please let me know if you have any questions about this content.